Hello, everybody, and welcome to Grand Rounds. Settle in, start eating, and ignore the clock in the corner, which has the wrong time. All right, so I'm very excited about today's presentation and to have Dr. Francine Conway here from Rutgers University, whose talk is entitled Generating and Maintaining Relationships Within Challenging Clinical Situations. But before I formally introduce Dr. Conway, I want to just mention a few housekeeping items. One is that at the end, we look forward to having a good discussion and getting some good questions. Please, if you're on Zoom watching this, write your questions in the Q&A box. And I will then read out to our speaker as many as possible. Also, it's important for people on Zoom to complete the evaluation of the session today. And so at the end of the talk, the link to the evaluation will be posted in the chat box. And there'll also be a slide with that link that'll come up as well. All right, so as I mentioned before, I'm excited about this presentation. I had a chance to work a little bit with Dr. Conway at Rutgers, and I thought it'd be really great to get her up here to talk about her work. So I'm glad it worked out. Francine Conway is a scholar and a clinical psychologist by training, recognized for her work in child psychopathology. She's a distinguished professor at the Graduate School of Applied and Professional Psychology at Rutgers and is the former dean of that school. She's also now the Chancellor Provost for Rutgers New Brunswick, which is the original campus of Rutgers University. Dr. Conway is a graduate of Cornell University and Columbia University and earned her doctoral degree from the Gordon Derner Institute of Advanced Psychological Studies at Adelphi, where she later served on the faculty for 13 years. Clinically, she's treated children in hospital settings and private practice for over 20 years. She's gained national and international recognition for her work on the psychodynamic treatment of children with ADHD and serves as the research editor for the Journal of Infant, Child, and Adolescent Psychotherapy. Dr. Conway has been an invited presenter for her work in many places, including the William Allenson White Institute, the Austin Riggs Center, and the Yale Child Study Center. She's done many media presentations as well, including several TEDx talks. And several of those, just to give some examples, are Cultivating Compassion for the Attention Deficit Hyperactivity Disorder Child, Shifting Our Stance from Moral Indictment to Empathy. Also, What is ADHD? Psychology in 60 Seconds. And the ADHD Compassion Project, Dispelling the Illusion of Children with ADHD as the Bad Other. She has authored many journal articles and book chapters based on her clinical and research work with children. And a lot of this work is summarized in her book, Cultivating Compassion, A Psychodynamic Understanding of Attention Deficit Hyperactivity Disorder, which was published by Rowman and Littlefield. She's the founder and director of Cultivating Compassion ADHD Project, which is a research and training clinic in mentalization-based treatment for ADHD children and their families. And I think I will say as well that Dr. Conway, I think, is a great role model for someone who can do clinical work, research, and administration, and also a good role model for people who should learn that there's more to treatment in psychiatry than CBT. It's very important to remember that. All right, anyway, without further delay, let me introduce Dr. Francine Conway from Rutgers University. So I'm going to keep this for later.
Thank you so much. Thank you for that lovely introduction, and good morning, everyone. I'm delighted to be here. Just get my microphone fixed here. So, you know, in thinking about what I would share with you today, I can imagine that you're used to, maybe you're used to hearing straight research with data and, efficacy studies and so on and so forth. So in speaking with the director of this program, one of the things that she wanted me to talk to is how does the work that I do apply to doctors, nurses, psychologists, social workers, psychiatrists across the board, folks who are interested in behavioral health. So given all that we've been through in the past couple of years, I thought I could share with you some of the work that I do and the techniques that I use, but also invite you to think about how this work may be applicable both to your training, to the work you're doing with your patients, and the community that you have, that you share with each other. So that being said, throughout my presentation, will invite you to think about some applications for the work. So we all know that, okay, let me see. Got an advancement? Oh, sorry. I need to show these disclaimers really quick. Okay. So we've all seen the headlines. COVID has been an issue, climate change, social justice issues, mass shooting, and definitely the mental health crisis in America. And patients show up with a diversity of contexts, right? They bring their social context, their family context, their environmental context to the relationship, whether it's a medical one, a behavioral, psychology one, or otherwise. And so medical providers, which I'll use that term to refer to all of us in the room, must find ways to develop and maintain relationships with their clients while attending to your own self-care. I think this was the first time in history that folks who provide mental health care were experiencing the exact same trauma as the folks that they were trying to care for. And so the benefit of going to a therapist is that there's some distance, right? They don't really, aren't going through what you're going through, so they can bring that objectivity to it. And I think that was all dissolved during the pandemic. So we have to find ways to develop these relationships, to maintain them, and to take care of ourselves at the same time. So this presentation offers a mentalization framework that helps us to do just that. So the question is, how do we generate and maintain relationships within challenging clinical situations? And these are some of the things that I'm going to speak to today to offer you a framework that I use that has some of these concepts that you may or may not recognize: attachment, empathy, reflective functioning, and mentalization. To talk through and think together with you the benefits of this particular approach. At the end of this presentation, I hope that you can identify at least 3 mentalization techniques that I'll speak to, and then understand how you can use this framework to promote developing a stronger therapeutic alliance with your patients. So the theoretical lens that I'll bring to this is a theory of mind and attachment, speaking about the emotion regulation circuit. I also want to talk about the compassion project that Stephen just mentioned, where I'll be presenting some case examples from the work that I'm doing in the ADHD clinic. Okay, so here we go. I want to start with man's expulsion from the garden. Some often refer to the story as one of the most famous myths in the Western world. The man and the woman were kicked out because they were bad, hence the original sin. Well, similarly, children diagnosed with ADHD are perceived as bad. They're expelled from our schools. And I came to mentalization by way of wanting to improve my relationship with my ADHD son. I needed to find a way to relate to him. His behavioral problems posed such a challenge for me. And I found myself just yelling at him all the time and telling him to stop and telling, do this, do that. And as a psychologist, I knew that that wasn't really healthy. So how can I have a relationship with him that allows us to preserve that bond? So I'll just say a little bit about what ADHD is. So it's a persistent pattern of inattention, hyperactivity, or both. It presents usually before age 12. And more recently, the DSM has revised the diagnosis that ADHD continues into adulthood. The symptoms are that they need to be present and inhibit functioning in 2 different settings. And they're not better explained by another disorder. Now, I'd like to do a disclaimer, which my disclaimer is that I don't believe in ADHD. So although I write about it and I research it, I don't really believe it. And I'll get to that in a little bit. But first, whoa. Okay. Okay, so I would like to show you a quick video about ADHD in a quick second, but I just want to say that that this figure shows the global prevalence of childhood ADHD. And what we can see is that it's a growing concern. It's actually the most diagnosed disorder in addition to learning disorders. It is prevalent and it extends into adulthood. It's disruptive. Children have difficulty completing tasks, keeping a job. Adults have difficulty keeping a job, performing effectively. So we're looking at a prevalence rate of about 11% in the US. Okay, so I'll play this quick video. Okay, fantastic. So what I'd like to speak to is the illusion. So here you see a puppy looking into his shadow, and what he sees is a wolf. In my work with ADHD children, this is how they're experienced. We see them as being disruptive. I mean, think about all the labels that come with being ADHD. You're a problem, you don't listen, you're lazy, you're disruptive, on and on and on. We are likely to see that image that the child projects. And you'll encounter these individuals in your lives and in your practice. So I'll take a few minutes to share with you the theoretical underpinnings of psychodynamic work with these children and their families. And I hope it provides you with some insight into how you may use a similar framework for working with challenging clinical situations. So this is the circuit. Relationship matters. And the earliest is the parent-child relationship or attachment. Many of us are familiar with attachment theory. It creates a safe haven for the child. It's a secure base. And Bowlby believes that attachment is necessary because it shapes how we perceive the world. But when there's a secure attachment, you learn how to trust others, how to respond emotionally, and how others will respond to you. Now, secure attachment leads to empathy. It's the feeling that you understand and share in the other person's experience, putting yourself in someone else's shoe. The secure attachment also leads to theory of mind or reflective functioning. Theory of mind is a concept where it's a developmental attainment, and it explains a developmental perspective in a child that emerges, I would say, around the same time that language emerges, that helps you to understand that you have mental states or psychological thoughts and feelings and so on, and also that you recognize it in other people. Without this reflective functioning capacity, it's very hard for you to self-regulate and control your emotions. So one of the challenges with ADHD kids is that they're impulsive, they have difficulty controlling their emotions. And so it really begs the question of do they have the capacity for reflective functioning? Now, when I talked in my TED Talk, when I talked about this, I got a lot of hate mail from folks saying, you know, I have ADHD. Are you telling me that I don't have empathy or I don't have the ability to reflect on things? And no, that is not what I'm saying, not the way in which the layperson at least thinks about it. And I'll go into a little bit more in a bit about what I mean by reflective functioning. But as you can see in this picture here, the baby is making a face and the dad is mirroring the face of the baby. This is the process through which we learn about our internal world. This is the process through which we understand and can connect with someone. It's called mirroring, and it's affect mirroring, right? It's attached to certain emotions. The behavior that you see outside is attached to emotions. However, there are times when there's, I would say, affect mirroring that's non-contingent. It doesn't really connect to the infant's internal state. And, you know, my disclaimer, second disclaimer is I'm not blaming the parent here. There are lots of reasons why this capacity or this ability to mirror your child does not exist. So for example, a parent who's depressed, they're really not responding and engaging with the infant. So there's no opportunity for the infant to learn about their own internal world and internal experiences. So reflective functioning is often used interchangeably with mentalization. So what do we mean by mentalization? So as you can see here in this little cartoon, the guy is saying, oh, I wonder if she's ever going to talk. And she's saying in her mind, she's thinking, oh, he must be shy or tired or something. I think I'm going to help him out. So it's your best guess at what the other person is experiencing. And we don't really know. Sorry, I lost my place here. In another little thing, I thought this was funny. He's trying to mentalize her. And he's saying, of course I care. I care about how you imagine, I thought, you perceived, I wanted you to feel. So we've all been there. We've all been there. And it is this imagining what is in the mind of the other and how it's tied to the behavior that helps us to form that human connection and leads to self-regulation. Okay. In terms of self-regulation, if there are impairments in the reflective functioning, you'll have this challenge in developing interpersonal relationships, social functioning, and personality development. And according to Shore, the prefrontal cortex is highly involved in this homeostatic regulation and attachment functions. And it plays an essential role in the interpersonal signals necessary for initiating social interaction between individuals. So as a quick recap, attachment is the development of that parent-child bond. Empathy, where you understand another's feeling. Reflective functioning, which is the ability to think and reflect on one's own thoughts and feelings and behaviors in terms of mental states. And mentalization, the capacity to do so. So we measure the extent to which someone can mentalize by looking at the reflective functioning. And in the Compassion Project, we use this a lot, and I'll go into that a little bit more. But there's some questions that I want us to wrestle with. Given the circuit that I just showed you and how everything really hinges on this parent-child bond and their attachment bond that they form, whether it's a secure attachment, disorganized, so on and so forth, can a patient's reflective capacity improve in therapy? Because regardless of what kind of therapy you do and what your orientation is, getting the patient to actually examine their own thoughts and feelings, I think, is a goal that cuts across all the different orientations. Then the other piece of this, especially in the psychodynamic world, can a therapist's own reflective capacity increase? So what if you're working with someone who's very concrete and they just don't think about their internal life at all. But they're able to follow the steps that they need to follow in a manual or whatever. Can we make a difference there? I believe we can use mentalization practices to improve this kind of a capacity that's really developed naturally. And I'll just say one more thing, that as at least in the psychodynamic therapy, the therapist sort of takes on that role of offering this corrective relationship between the patient and the therapist so that they can repair some of these ruptures that happened in early childhood, which again follows that it'll increase the patient's capacity for reflective functioning. So for our remaining time, I would like to look at how do we evaluate reflective capacity. I'd like to look out for what I call pre-mentalization or pseudo-mentalization states. You know, that's like, you know, you meet this person, they speak so insightfully, but yet their behavior doesn't really add up, and like what's going on there. And how do you, as a clinician, therapist, nurse, whatever your discipline is, take a reflective, mentalizing stance vis-a-vis the folks that you're working with? So I'll start with evaluating reflective capacity. And I want you to think about these questions for a minute. To which parent do you feel closer? Why do you believe your parent behaved the way they did when you were younger? And do you believe your experiences with your parents have any effect on who you are today? When we think about questions like this, these are the kinds of questions that are posed on the adult attachment interview. And we offer those questions to the parents that we're working with to get a sense of their reflective capacity and their capacity to mentalize. Okay. What's important here is not so much the details of your answer. You know, my parent, you know, she spent a lot of time shopping, or my parents spent a lot of time baking cookies. The content or the sort of experience that you relate is not really the point for purposes of this presentation. What we want to think about is whether or not the person you're asking these questions of can articulate and take on the perspective of someone else. So when you ask these patients these questions, you're listening for their ability to reflect on their thoughts on the matter, to imagine what is in the mind of the other person. And more importantly, one would listen for the patient's capacity to link their mental state to their behaviors. And these can all be scored. We videotape all of our sessions. And so the students who work in my lab are scoring and coding this data to see if the narrative, if the responses that they're given, you know, indicate some capacity for reflection. Okay, so let's do a quick exercise looking at the relationship between reflective functioning and empathy. So imagine I asked the question, why do you believe your parent behaved the way they did when you were younger? We can imagine an individual with low reflective functioning and low empathy responding, I have no idea, and not showing any concern about it. Whereas someone in the low reflective functioning, high empathy quadrant, there may be some expression of concern, but still a lack of, you know, I don't know why my parents fought, but it bothered me, right? So they're unable to think about how the behavior is linked to the mental state. On the other hand, a highly reflective response to the question could either be one that shows some reflection about the current mental states of the parents, but with little concern. My parents fought all the time. What is the big deal? And in the final quadrant, the response could be, my parents fought all the time, and that made my mother sad. And even me, I was worried for her. So you can already see the quality of the response changes. And when you're working with clients and you're working with patients, you want to get to that space. You want to get to that reflective space, because it is in the process of reflecting that you're able to manage and regulate your emotions. So as we listen to our patients or others in the therapeutic relationship, it is also essential to remain vigilant for what I call the pre-mentalization state or pseudo-mentalization. And there are three that I want to share with you. And they really focus on how one's thought process is situated vis-a-vis reality. With psychic equivalence, and Peter Fonagy, this is Peter Fonagy's work, he talks about this concrete, rigid thought process that gets paired with unrealistic certainty. So for example, someone does not return your call and you're convinced that they're angry with you, right? So it's how you're feeling becomes reality. And some people call that defenses, but you can see it even in, relationships with individuals who are on the borderline personality, access to range, going into a fit of rage over, you didn't call me back or you didn't text me back or something like that. The pretend mode, which is the second one, the thought process here in the session with your client has no basis in external reality. So there's a decoupling of internal from external. And as I share some of the vignettes later, you'll see this happening with the patient. So the patient is an active participant in therapy, comes to every session and talks the entire session hour or 45 minutes. But then you find out that this patient has two psychological presentations that are separate and disconnected. They're one way with you, but the evidence in their lives indicate a lot more turbulence and disruption, but they don't put it together. They don't bring that into the room. And then the last pseudo-mentalization state or pre-mentalization state I'll speak to is the teleological mode, right? So it's a belief that mental states are only real if they're reflected in the behavior that the client wishes. So, saying to your therapist, can you can I call you outside of the therapy hour? And, a good therapist sets boundaries and say, we can talk now and we'll see you next week or whatever the frequency is. And then the patient becomes upset. If you cared about me, you would let me come in and see you even when we don't have an appointment. Okay. Now, there's some mentalizing problems that you can see right there in some of those examples I give you. The one that I want to really point out here is the mentalizing breakdown. So this is when, and it can happen in the parent, it can happen in the child, and it can happen in the therapist. So in my world, sometimes we refer to this as countertransference, where a patient really pushes your buttons. I mean, you are just ready to go off, but you can't because it's unprofessional. So you're having a mentalizing breakdown, or the parent just loses it on the child, or the child loses it on someone else. The capacity is there to mentalize, but these kinds of breakdowns are usually triggered by high affect or trauma. And there's always something that sort of pushes that button or that vulnerability. So I'm going to switch to talk about the model that we use and what are some of the techniques that we use. So these are some essential features of the model. Taking a mentalizing stance, which I'll go into in a bit. Use of metaphor or focus formulation, and then many layers of mentalizing where everyone is just mentalizing each other. The therapist to the child, therapist to the parent, encouraging the child to think about what's happening in the mind of the therapist, what's happening in the mind of the parent, and so on and so forth. It happens between the supervisor and the supervisee, and so on. So how do you take a mentalizing stance? Curiosity, that is the first sort of hallmark of a mentalizing stance, being very, very curious about what's going on, because as I said earlier, it's your best guess of as to what's happening in the mind of the individual. And really for us to respect that we don't know. You can imagine what things are like, but you really don't know. And so expressing that curiosity really is the way that you stay in this particular framework. And then the therapists want to model mentalizing. You want to share with the patient, you know, when you came in, you seemed really upset to me. Did I get that right? What's going on? And just being very curious about that. Modeling that sort of questioning and curiosity. Paying attention to highly charged emotions, as I said before. And when the patient is in a non-mentalizing stance, quickly returning them or trying to return them back to this position of inquiry, curiosity about what's happening in the mind. So this is what not to do when you're mentalizing. Could you play that? But it's called It's Not About the Nail. And it's a video of this woman sitting with a nail in her head, and she's talking to her partner, and he's trying to get the nail out and saying, if she's saying, you know, I have these headaches, it's really bad, I don't know what's going on. And he says, can I just, and she's like, stop, you're not listening to me. I'm telling you, I have these headaches, I don't understand it. So anyway, it's that kind of push-pull that we sometimes observe when two folks are interacting. And the point is that she doesn't want him to solve the problem. She just wants to be understood. And it does feel good when people understand us and what we're trying to say. Okay, so this is the Compassion Project that I'm currently running at Rutgers. We have a pre-treatment phase where we do the child attachment interview, strengths and difficulties questionnaire, the Hampstead Child Adaptation Measure, reflective functioning questionnaire given to the parents, not to the child. And then we look at some behavioral scales. Then we do an intervention, which I'll say a little bit about in a minute. And then post-treatment, we give the same measures again to see if there are any changes. The treatment itself, there's a book, this was developed by Midgley at the Anna Freud Center in London, and they've used it with other kinds of diagnoses, but not with ADHD. And for me, the model is one that does not really focus on the behaviors of the child and the problems, but work on developing this reflective capacity in the child. So the first meeting is with the parent and the child, do all the measures. Then we have a second session together with the family. It could be mom and dad, child, therapist. And we talk about, you know, describe this child's problems, tell me what's going on. And then we have toys, because the child treatment, and the child gets to pick out a toy that reflects his sort of, is a metaphor for his experiences. So children have picked things like, you know, a fire engine or, you know, Superman or something like that. And then the child gets to pick an animal also for the parents. And one of the cases that I can think of that was really powerful was this child picked for the mom an ant. He says she was an ant. For the dad, he was a gorilla. And for him, he was the baby chimp. Later on, we found out that this husband had taken away the mother's passport, had threatened to take away her kids from her if she left him. And really, there was a lot of intimidation and violence in the home. And it was interesting that he saw his mom as this aunt, right? So one of the things I like about working with children is it's very explicit. You don't have to interpret much. I mean, they just put it right out there for you. So, okay, so in our clinic, it's really a mentalization-based treatment. And then we have 6 weeks of sessions. The parent are in the session with the therapist once a week, and the child meets with the therapist once a week separately. At the 6-month mark, everyone comes back together, look at how things are going, do an assessment of where we are, and then another 6 weeks of the mentalization-based treatment. And then we end with an assessment phase. And we follow up with the families 6 months later. And the reason why I sort of came up with this model, not only because I wanted to figure out my son, but as a therapist in my private practice, I would have these kids and families, and they're really in a lot of discomfort. And, 9 times out of 10, the parents also struggle with the same issues. So you're telling them to be organized, to make the session on time, to do the assignments. It just doesn't happen. And I needed to find a different way. And so the focus of this, if I had to summarize it, is how do I improve the relationship between the parent and the child? And I say to the parents, look, the world is going to beat up on this kid hard. They're going to get hard hit. So we don't need the parents to add to that by, beating up on them further. And trying to get the parents to have some empathy and compassion, which is very hard when your child appears to be willful and disobedient and breaking the rules and all this kind of stuff. So that's the model that we use. And so far it's going great. And I'm going to share with you some of the things, but here are a few assumptions of the model: that children have inner lives. And you would not believe how many parents never thought about that. They never thought of their child as having their own thoughts and wishes and feelings, which is mind-blowing to me because children are very imaginative, and that's one of the definitions of childhood in a way. And because we recognize that a child has an inner life, we think about how can we have this child mind in our mind as a therapist. This is the work of mentalization. We believe the internal world shapes the child's behavior, and ADHD can stem from relationship ruptures that lead to anxiety and depression. Many children who present with ADHD actually have significant depression and anxiety. And we also know that reflective functioning emerges in the context of the attachment relationship. And when parents cannot consistently mirror the child's behavior, the child's internal affective states or experiences confusing and challenging to regulate. So as a reminder, reflective functioning can be impaired. And if you're working with a child who has this impaired capacity or diminished capacity for reflective functioning, it stands to reason that this child will not be able to control their impulses, will not be able to organize themselves internally to follow rules or do whatever they need to do. And actually, the research has shown that most ADHD kids do have difficulty mentalizing. So here's a case example from my project. So let's consider this family drawing. And I'm going to present you with vignettes that explains how the model works, more so than reporting on the data, so you can invite me back next time and I'll tell you about that. But so let's consider this family drawing. So this is Sarah, and she was part of our compassion project. Sarah has 10 siblings. And so she drew pictures for each sibling. Now, to the right of the screen, that is Sarah. She identified herself. And then she's looking at the other 2 images. Those are folks who are members of her family. And in the dialogue with Sarah about this, one of the things that came to light, and I don't know if you noticed this, is that from Sarah's perspective, the family members' backs are always to her. The therapist then begins to work with Sarah to imagine what is in the mind of the other, of these family members who have their backs to you. And then Sarah can begin to kind of think about it. Excuse me. The therapist expresses curiosity. Well, what do you think and what do you feel when you see, your sister with her back to your parent? During these sessions, Sarah began to express feelings of loneliness that she could not verbalize earlier in the work. And through the mentalization-based treatment, she's become more aware of and comfortable with the dynamics between her family and the motivation behind their behaviors. And this is a 12-week treatment. Pretty remarkable. I mean, I really didn't, I've been doing this now for 3 years, and the impact of this very, very simple model, when you speak to people's insides, it can really transform things. The next case I'm going to present to you really quickly, I don't know if I'm running out of time here, is the case of Johnny. He's 8 years old. And this is a boy who could not stay in the classroom, all the typical ADHD things. And one way in which we kind of imagine this work together is the therapist would take him out to the basketball court, and he's throwing the balls around and she's talking, right? She's just saying, oh, you're throwing the ball around. And I think for a lot of my students, this is like boring, right? Like you just, oh, you picked up the ball. Oh, you threw the ball around. Oh, you threw it really hard. Oh, you threw it really soft. So she's trying her best to engage this kid. And one day in the work together, the therapist helps him to become aware, because she's constantly encouraging him to mentalize and share what he's feeling. And so one day she came in and she had a cup of coffee on the desk. And so he starts expressing curiosity in terms of what's in her mind. And he says, where did you get the coffee? And when they're playing basketball, he says, oh, are you disappointed you did not make that basket? And he begins to keep her mind in his mind. And this is a huge shift from a child who didn't even recognize the other to now actually thinking actively about what's happening in other people's minds. And it really did transform his relationship with his peers. He stopped doing a lot of the behavioral challenges that he presented with. Stephen, how much time do I have left? Okay, so I'll just wrap up that one of the things that we do is this is just another case example, which I'm not going to get to, but in terms of professional application, mentalization does improve self-regulation. It does build trust. And in the group supervision, what we do, the way our clinic is set up is the students have an individual supervisor where they talk about the case, but then they have group supervision. And this gives an opportunity for them to feel nested and like the reflection is happening in the group supervision. So they're presenting their cases and they're hearing from their peers who are trying to help the therapists remain in this mentalization framework. It's a challenge because you do need people to feel safe so that they can discuss some of their challenges. And it's an opportunity to teach reflective skills. And, there's also this sort of shifting between the different poles, if you will. So things that are, self versus other. So even as you're working and you're listening, is this about the self or the other? Is this about cognitive processes or affective processes? Is it automatic or controlled? Is it internally focused or externally focused? So you can really start to go down that path. And then in terms of the village, the group's task is really to validate the therapist's response to the client. And it's the way that I create that sense of safety is saying, let's imagine together what's going on. Let's listen together and let's be really curious. And there are times when the therapist comes in and there's a crisis and I really, really want to talk about this very upsetting thing that's going on. And the supervisor, me, the role is to really slow things down and really try to make that connection between the inside and the outside. So just want to thank all my numerous doctoral students and colleagues who work with me on this. And my goal is to get these kids back into the garden. Thank you.
Okay, thank you, Francine. And now we do have time for some questions. Mike?
I question, and it might be too academic, but you talked about not believing in ADHD. Watching the presentation, I might add to that or nuance that and say you don't believe ADHD as an idiopathic specific cause.
Correct.
You're not suggesting that all of the wealth of data about it as a phenomenon with prognostic implications. Not really.
Correct. I don't think that we know exactly what's going on with these kids. And so the treatment of choice has been to medicate and CBT, and it's not working. And there was a big study done called the MTA study that showed these gains attenuate after a year, right? So we're just trying something different. And we do have some cases where the child has to be medicated because of the neurological challenges. But even then, my particular approach is we live in a relational world. Regardless of what you present with, you have to be able to have relationships with people. Otherwise, life will be kind of rough for you. So.
Okay, we got a couple more questions. I forgot to-
Hello, thank you for that presentation. So my question, I was thinking to your kind of first vignette where you showed a patient and how she drew family members with their back to her. I'm curious about, and maybe in the earlier stages or throughout the process, how much of a role does sort of creative arts therapy or artistic approaches kind of set the stage for those initial parts of mentalization? And do you think those would be translatable through the developmental spectrum?
Yeah, that's a great question. Thank you for asking. I think it's all imaginative and creative, right? There's no way of knowing for sure what is in anybody's mind. And the beautiful thing with kids is that they love to play. So they will use the toys in the room and use the metaphors and use the symbols. And it's easy to talk to them about it. There was one child who we had a hard time figuring out a metaphor for this child and coming up with a focus formulation because the child kept talking, and it's usually boys, about Among Us. I don't know anything about Among Us, but apparently, you know, there was this rocket and it was taking off and coming back down to earth. And what we came away with realizes this child's world was so disorganized and scary that that's what he connected to. So yes, you can use those throughout the developmental phase. I think when you get to like adolescence and children, young people are a little less into the playing and more into the talking, but it's very, very, very helpful. And we go back to those initial focus formulation as a way of helping the parent to have some empathy, right? So remember, he's Superman. And, you know, one of the interventions, it's like, well, does Superman sleep? Does he eat? So he's not always like Superman. So when parents are saying, you know, it's kind of like solution focused therapy and sort of using that kind of line of query, like, yeah, he's hyperactive, but he isn't always hyperactive. So let's look for those opportunities and sort of encourage that.
I'm going to have to encourage people with questions to sit in the aisle.
I just want to say thank you so much. This was a wonderful talk. I am the CL fellow here for psychiatry. And from the adult psychiatry side, I think a lot of us are struggling with a lot of adults who come in with complaints of concentration, often an internet-related self-diagnosis of ADHD.
Yep.
And it's very, very difficult, particularly, you know, stimulants. Do you give them a stimulant? There are downsides. And one of the things that I've, you know, struggled with and wondering your thoughts on is a lot of times patients are relating symptoms. It can be tough to get into, in terms of aspects of the interview or the therapeutic interview, getting at affective states and relational aspects when you have an adult, and particularly in a time limited setting where you don't have access to collateral. Do you have any thoughts on how we can refine our ADHD assessments from the adult side?
Yeah, that's a great question. And, you know, some of the prompts that I gave you earlier can be used, right? So you can do a quick assessment of reflective capacity and you sort of know, or you can imagine what it might be like to sort of engage this person. And, you know, they may be very concrete on the one hand. They could also be pseudo psychological on the other hand, right? So you can ask a couple of questions that get at what do you imagine this behavior means? What do you imagine is in the mind of this person? And just kind of do a quick assessment of their response. And I believe whatever the treatment is, if you can include this sort of mentalizing approach, it can help to build that trust. It can help them to start learning that looking at their thoughts and feelings is not such a scary thing. And it is in that process of self-reflection that their ability to control themselves increases and improves. So I hope that answers your question.
Okay, well, we do have time for another question or so, and if no one here,
Oh, there's a
okay,
question.
I was going to ask one, but I will sacrifice my question. Dr. Choi's question, which I know will be excellent.
I'll make it a quick one. Thank you so much for the talk. I saw that you, part of the Compassion Project, one of the component was training teachers for mentalization. The reason why I want to bring it back to there is I'm a psychiatric consultant to non-psychiatric medical providers, particularly cardiologists and surgeons and nursing providers there. And recently there's been questions asked to me about how to engage with patients, as you suggested, adults and the access to particularly cluster B traits. And, you know, these are providers who need skills to be able to work through these challenging moments when they engage with their patients, but their ultimate goal is not diagnosis or treatment of those psychological symptoms. It's really get through that so they can provide medical care. And they often express to me they feel abused by their patients. They feel that it's going nowhere. You're telling me to take all these stands, whatever, supportive, compassionate, but it doesn't really matter to me at the end of the day because I need to give them the medications that they're throwing back at me in my face. So how do you provide some of these skills to those folks who are not necessarily in a psychiatric setting?
Yeah, you know, the good thing about human beings is that we all sort of share this experience of early relational lives, right? And that a patient who, or me or you or other folks, all go through this on the spectrum of secure versus, you know, disorganized attachment. So it's, you can't heal that in 2 or 3 meetings or maybe a year of meeting. But what I would speak to is this person's, the trainee's ability to feel supported by each other. So if you do the nested supervision and a group supervision where you have a place to reflect and to talk and share your approaches, that can help them get the internal sort of bolster them internally so they can do their jobs. The other thing I would recommend is how you approach folks. Ask them to talk about themselves. People like to hear themselves talk and they like to talk about themselves and they like to know that you're interested in who they are. And then it really shifts the relationship, you know, from here, take these medication to, oh, this person maybe is interested in me. So those would be the quick thoughts, but.
Okay, well, I want to thank everybody for coming. I want to remind everybody to please complete the evaluation. I want to thank Dr. Conway for a really stimulating talk on a different approach that we haven't heard about.